Hello everybody and welcome to Shock and Bleeding Control. This is a fairly quick chapter to go through. I think I have about 40 slides, so it shouldn't be that bad. We're going to power through this in one complete training instead of breaking this up into groups. At the end of the day, what I really want everybody to remember is that shock is a pretty simplistic idea to kind of manage, and that literally boils down to inadequate tissue perfusion. So if you understand that shock means nothing else other than all of the cells in the body are not getting the adequate oxygen and nutrition supply, as well as waste removal, this will be really easy. There are different varying stages of shock and different types of shock, but for the most part, altered mentation is your biggest tattletale on shock in itself. And understanding how we get to the point where somebody's mentation would becoming altered is really the biggest thing. So with that being said, we're going to get into the introductions. So as this says, the lesson goal is describe the signs and symptoms of internal bleeding, external bleeding, shock, and care of patients with these conditions. And it's quite literally stop the bleed, right? If at all possible, we're going to stop it. Describe the causes of shock, its signs and symptoms, and the consequences, and be able to provide appropriate care. Shock hypoperfusion means a state of collapse and failure of the cardiovascular system. Again, let's just simplify this. It literally means that you are not getting adequate tissue perfusion. Oxygen on, nutrition in, carbon dioxide off, and waste products out. That's it. It's that simple. So as shock progresses, blood circulation slows and eventually ceases, and that's just purely due to the fact that the cardiovascular system is not a Swiss watch, so to speak, right? It can only do so much before it tires out. It doesn't matter what muscle or tissue that you are asking a high demand from. It's only going to be able to perform at 100% for X amount of time. In its general state, it's probably performing at 30 or 40%, and it has a much longer time frame, right? It's not taxing its own system, so it can't reach that failure point. Fick principles. This is something that you guys should probably know. It's actually one of the simplest methods to come across and figure out how perfusion works. But in reality, it's something that a lot of people like to ask you about so that they understand whether or not you actually understand what's happening with the body. And in the Fick principles, we're talking about oxygen into the lungs, which is ventilation. Oxygen into the blood, which is pulmonary respiration. Oxygen circulated through the body, which is the cardiovascular system pumping oxygenated blood to all the tissue it needs. And then oxygen into the cell, which is cellular respiration. Remember, ventilation and respiration are completely different body systems. Ventilation is the mechanical means of getting air into the lungs, and respiration is exchanging gases and nutrients at the cellular level. Cellular metabolism. All cells require adequate perfusion. Some may work on anaerobic metabolism for a short amount of time, but the brain and the heart do not. And so before we get off into a segue, let's just talk about what adequate perfusion is. And as you look at the illustration, you can see the capillary bodies, and it goes from the arterial side to the venous side. And when we're on the arterial side, we've got that nice red coloration that's symbolizing that it's oxygenated. We're going to have diffusion across the membrane where the oxygen moves into the tissue, and then the waste products and CO2 is going to diffuse back into the bloodstream. We're always looking for that balance. So while not all cells are going to carry oxygen at the same exact time, we have enough that the cells are able to actually kind of balance, and we have that homeostasis again. Remember, we're always looking to keep the human body in that middle port. We want to make sure that our pH stays at a 7.35 to a 7.45. We want our end tidal to be a 35 to 45. I mean, there's just this real fine, delicate balance of where the body wants to be efficient and comfortable. Oxygen may be insufficient because of problems affecting any of the Fick principles. And so we can kind of look at this in a couple of different ways, right? So oxygen into the lungs. If I have asthma, I may be able to get gas in, but I'm not getting that adequate gas exchange. And again, it's all about diffusion and balance, right? We want homeostasis. So if I can't get the expelled air back out of the lungs to get rid of the carbon dioxide, I can't actually afford the red blood cells any more opportunity to unload oxygen. So there's that diffusion mismatch there. The next part would be the cellular respiration in the lungs, right? And that's that gas exchange across the alveolar membrane. And then circulation. So long as we have a strong pump and intact pipes, we should have some kind of good circulation. And then we have cellular respiration, yet again, where we're making that gas exchange based on balance. So this says the inefficient production of small amounts of energy for a limited time. That's anaerobic metabolism. And if we're sans oxygen, right, so you use a tourniquet and you cut the blood flow off to a distal part of an extremity, that tissue will end up going anaerobic. It will survive, although it is going to have some kind of damage. It just so happens that the damage is fairly minute in normally healthy individuals. So when we have somebody who's perhaps, say, bleeding quite significantly and they're not able to get oxygen pushed to those distal tips of the fingers or something like that, we're losing that tissue. Accumulation of acidic waste products. So one of the things that happens when the body burns sugar is if it's got a really efficient combustion process in burning sugar to use it as fuel, it uses the oxygen in the sugar, and the byproduct is carbon dioxide and water vapor. That's just two of the things. Carbon dioxide is acidic, and we can build up what's called lactic acid, and that's a byproduct of anaerobic metabolism. It's because we weren't able to actually get the CO2 off effectively, and so we had an overload of CO2, which then becomes lactic acid, and that actually gives you that burning sensation when you're perhaps performing those extra reps on your workout. When we're talking about fluid compartments, there are generally three systems or three fluid spaces that are known, right? So we have intravasculature, which is inside the vasculature. And one thing that everybody should really actually understand is that blood, or the products of blood, are highly toxic to other tissues. If you've ever had a bruise where you have that big dark purple kind of ring or spot on your, some part of your body, and you touch it, it's painful. It's painful for a reason, because that product of blood is actually necrotic to the tissue that it's in direct contact with. It is designed to stay inside the vasculature system. So intravascular is inside the circulatory system, and we want every last drop of red blood to stay inside of it. Intracellular, the human body is made up of mostly water. So approximately 70-75% water, depending on your fluid volume and intake. All of the cells in your body require some kind of water to maintain their shape and their integrity. There's vital things that are kind of floating around in that solution, and so that is its own water supply, and it becomes exchanged as well. And then we have interstitial, which is somewhere in between. We have in between the cells and then not really in the vasculature, and it'll end up kind of being absorbed by the lymphatic system. So this is water, and some substances move freely among all three compartments. And again, that's that kind of a diffusion osmosis principle. You really just kind of need to understand that water has a static pressure throughout the body, and it will go to low places. It wants to balance everything out. Anything else that's inside the body, if it wants to be pushed into a cell, it requires a carrier, and this requires energy. So again, one of these things is I keep touching on, say, diabetics, and we require energy to produce insulin, which is the key to unlock the cell to allow glucose and amino acids into the cells. Without the ability to create insulin, then the sugar will stay in the bloodstream, causing hyperglycemia. So we're still looking at fluid and plasma, and as you're looking at that, you guys should really kind of take into effect that you're looking at oxygen trying to cross those two membranes, right? We have the cell and we have the capillary wall. The oxygen wants to cross the two membranes, it wants to balance, and so by doing so, it's going to push carbon dioxide back off. You can see a sodium and a potassium shift. The sodium is leaving the cell, and potassium, the K plus, is entering the cell. Proteins are kind of moving in a circular motion as long as the amino acids are doing what they're supposed to do. So in this diagram, we're looking at a really, really basic circulatory system. You guys can see the 4 chambers of the heart. You can see the great vessels. You see the vena cava. You see the arterioles and the artery and the aorta. And so if you're looking at it, you guys can actually really kind of see this pretty quickly. Is anything that's deoxygenated comes into the right side of the heart. It's pumped out deoxygenated through the pulmonary artery. Remember, if it's leaving the heart, it's an artery. It's not about the oxygenation. And then it goes into the lungs. And then you can see that pulmonary artery breaks into arterioles and into capillaries, which are all surrounding the millions and millions of alveolar membranes. Then it becomes oxygenated. It comes back in the pulmonary veins. It's now red. This is the only time that you're going to see a mismatch of the colors. It comes back into the heart on the left side, into the left atria, goes into the left ventricle, and then gets pumped out through the aorta to the rest of the body. So if you're looking at that, you can see there's 2 main trunks to this. We have the major trunk to the torso and the extremities, and then we have the brain. Now your brain is one of the most hungry organs that you have. It needs 25% of the available glucose at any given point in time, and sometimes can actually require quite a bit more based on what you're asking it to do. It's really, really lazy as well, so it can kind of shut parts of itself off to kind of really conserve energy. But if you're looking at the diagram, you can see that there's a heavy emphasis on the head, right? So there's its own complete circuit that's coming up, and it's, again, arteries to arterioles to capillaries, and then deoxygenated, and it's leaving back through the venules to the veins, and then we get into the superior vena cava. It's its own kind of circuit. It's really, really expensive to have something so significant inside your head. And then the rest of the body shares the other remaining parts of the bulk of the blood flow. So if you're looking at the aorta, and then you have some small branches to the arteries there, you can see that those are going and breaking down. Then we get back into the arterioles, capillaries, and then into the venules and back into the veins, with the major vessel or the great vessel on the deoxygenated side being the inferior vena cava. And inferior and superior is literally just above or below the heart on where it's entering. All right, so this picture is back again, and all it's saying is if you're looking at that cell, there is a massive majority of that cell is just water. You have the nucleus, you have the cell membrane, and there's some obvious parts that are floating around inside the cell, but overwhelmingly, most of your body is made out of water. Now, if we're looking at the interstitial space, it's pointing out that it's in this gray area between the vasculature and the actual cell. And that's pretty typical, right? So if we have water pressure that's creating water that's going to leave the capillary bed and it's going to transport itself to the cellular tissue, it needs to go through the interstitial space. So it's really not there very long. These are things that can kind of run amok when people have poor circulatory systems or other body systems that are not running correctly. Here we go with the inadequate perfusion of tissues with oxygenated blood, which leads to hypoxia and the buildup of metabolic waste. So again, if I can't get oxygen and sugar to the cells, get carbon dioxide and the waste products of cellular metabolism out, I am not adequately perfusing that tissue, and it is now going to be in shock. Simplistic diagram, you guys can kind of see that we have a little bit of a GIF there, or GIF, however you want to say it. If you guys are looking at it, it's supposed to be a pump, the fluids, and the pipes, right? And so the large cylinder is supposed to symbolize the overall reserves. A typical adult has 5 to 6 liters of blood volume inside their body, and so that's saying like, hey, look, this is how much we have in overall, and then you've got to pump in and out of that into the actual pump itself, which is the heart, and you can see the blood flow tracing through that as it goes through its slides. So if you're watching the arrows, you can see the superior and inferior vena cava feeding into the right atria, and then it feeds into the right ventricle, which then goes into the pulmonary arteries. It then gets pumped back into the left atria, into the left ventricle, and then out to the arterial system. So we're going to call this the perfusion triangle. And again, this is nothing more than the simplistic idea of a good pipe, a good pump, and then a good amount of fluid. If we have all three in balance, we have a very healthy, non-compromised cardiovascular system. So damage to the heart, which could be anything from a arrhythmia or a cardiac event causing an AMI, can cause tissue damage. One of the few organs that's not able to rebuild itself when there's damage is the heart. And so when that particular section of cells dies, they're just dead. They now just kind of are along for the ride. They're unable to contract anymore. And so that will actually lower our ability to create pressure or to push against the pressure that's in the vessels. And so when we're looking at the next side of the triangle, you have the blood vessels. And so, and this is pretty much just telling you that, much like a plastic bag, fluid will conform to any shape, but if you were to squeeze that plastic bag down, you could create pressure in it. All of the vessels in the cardiovascular system have some kind of some kind of musculature, and they are able to dilate if the body tells them to, which is just a relaxation of the smooth muscle tissue. And if they do so all at once, we still have the same amount of blood flow, but we just don't have the pressure. So, and I should probably clarify that. We have the same amount of blood, and we're just not efficiently pushing that through the body. And so then when we look at the last section of the triangle, that's the blood. And when we're looking at that, we want to make sure that we have adequate red blood cells, we have the right amount of plasma, we have the right amount of fluids that are helping to maintain volume. Because volume and pressure are kind of inversely related, and the entire three sides of this triangle are necessary for something that's healthy. Okay, so how do we get into a situation where we have shock? So we can have pump failure, low fluid volume, or poor vessel function. And we'll talk about this again, right? Like pump failure, I have a heart attack and I lose a big chunk of heart cells that are unable to contract anymore. Now my ejection fraction has gone down. I'm unable to pump against vascular resistance. And so this creates a negative cascade of events. If you get into low fluid volume, that's quite literally, I spring a leak, right? Something happens traumatically or even not traumatically. Maybe it's just a GI bleed, but I am losing the actual fluid that's going to carry oxygen and nutrition to the cells. And so if we have a leak anywhere of any type, it's a bad thing for us. And then we have poor vessel function, which really gets into when we're taking certain drugs, or perhaps we get septic, right? If somebody becomes very septic, they become very acidotic, and this will also cause the vessels to just vasodilate, and then we'll completely dump the pressure. And if I dump the pressure, the pump itself is not able to compensate. It can only go so fast to try to keep that pressure up that we need for the tissue to be receiving that oxygenation and the nutrients. So we're going to talk about a couple different types of shock. The first one is going to be cardiogenic shock. This is internally caused, right? And intrinsic means internal, or like it's inside of itself. And that's myocardial damage. So I kind of touched on that, right? We have an MI. We lose a big chunk of heart tissue. It's no longer able to do its job. And so we're unable to actually create the pressure that we need to create so that we can get perfusion across there. We could have a dysrhythmia, right? AFib, aflutter, VTach. VFib is a terminal rhythm. So when we're looking at these, if the heart's not functioning the way it's supposed to, I'm unable to generate that pressure and create that blood flow. And then valvular disruption. This is when I have something where, I have a prolapse valve. I'm sure a lot of people have heard the term murmur, but a murmur is usually something that children grow out of, and if they do have it, all it means is that we have a little regurgitation of blood from one chamber to the next. On a valvular disruption in its entirety, you can absolutely have a valve rip, and then every time one part of the heart squeezes, it just pushes blood to the least resistance, which is going to be the other side of that valve. So we're still looking at cardiogenic shock, and then now we're going to kind of talk a little bit about obstructive shock. And this is a little bit on its own, right? So obstructive shock is like something like cardiac tamponade. And when we say cardiac tamponade, we're really looking at a couple of different things. You could have a traumatic event where, say, a vessel blows out on the heart, and it is sitting in the pericardium, which is, remember, that sac that sits around the heart, which allows the heart to move against the lungs and other parts of the body without creating friction. But if it was to bleed inside of that sac, every time the heart contracts, it pushes a little blood into the sac and it squeezes the heart down. No different than if you were to squeeze a sponge between your two hands and then you're hoping that it's going to keep holding water. But as you get closer and closer together, it's unable to actually hold any more water, regardless how many times you dip it underneath water level. Then we're talking about something like a tension pneumothorax, right? And this could be a tension pneumo or a hemopneumo, which the only difference between the two is one is caused by air or gases, the other one's caused by blood. And so that's, again, one of those things where if we were to have a small, say, blowout in the lung tissue and air was escaping into the pleural space, that air will actually create enough pressure that it will collapse the lung, much like that sponge I was talking about earlier, into inefficiency. And what ends up happening is that lung will actually start to shift over away from where the gas is escaping into there, and it starts to push the lung, which is now dense tissue, against the heart. And so that tension pneumothorax can most often actually cause the heart to have its own tamponade. It's just not going to be a cardiac tamponade. All right, now we're looking at distributive shock, and this is vasodilation. The blood volume stays the same. I've just increased the size of the bag that it's in. So again, I'm looking for a specific pressure. And I might have said it before in one of the earlier lectures, where the kidneys need to see a specific amount of pressure so that they understand that they're being perfused and that they're getting the adequate tissue perfusion, they're getting oxygen and nutrition and the waste products pulled out of them. The rest of the body needs this as well. It can actually run pretty low in pressure, but at a certain point, the only thing that the body's going to want to do is perfuse the core organs, right? Because we don't want to go into organ failure. That's going to be the brain, the heart, the liver, and the kidneys, right? Above all things else, those core four need to be perfused. It's just mandatory. If we don't perfuse those core organs, we're going to die. So when we're looking at distributive shock, if the pipes become larger in size because they've released any muscle tension, the pressure drops, we're unable to get the heart to compensate, right? We're asking it to do a lot more. It will attempt to auto-regulate by increasing the rate, but at a certain point, the rate can only go so high and it can only do so much. And if we just can't actually spin it up fast enough, the pressure continues to drop, perfusion continues to drop, and then we start to see organ failure. So some of the causes for distributive shock are neurogenic. And so in that's quite simply just somebody goes into some kind of neural component, or they have some kind of trauma, right? And then we have the spinal trauma, which if you sever the spinal cord or you compress it and you're unable to let the spinal cord send signals to the small, smooth muscles inside the vasculature, once they're not told what to do, they just completely dilate. And so in the trauma stuff, you'll see this quite often when we're talking about a line of demarcation. So let's say that you undress a patient who's been in a motor vehicle accident or a motorcycle accident, what have you, and you see a nice pink line somewhere along the torso. And everything from there down is really warm to the touch, it's really pink, and they're obviously flaccid. So one of those things is the spinal trauma is causing the body the inability to actually tell those vessels to squeeze to create pressure, which will have a patient with really low blood pressure. Sepsis again, we're becoming acidotic, we have that severe infection, and then the capillaries basically become a little bit more permeable, and we start kind of third spacing some of that fluid. Anaphylaxis works much the same way. We have that histamine response, and we're trying to get the chemical mediators to the offending agent, and so the body will open up the vasculature and allow it to third space interstitial fluid and other things across the capillary membranes. That's where we get the urticaria or the hives. And then psychogenic is somebody who's having a psychological episode where I'm not sure that I see it very often, if I've actually ever seen it at all, but they're able to work themselves into a kind of frenzy, so to speak, where they will actually cause themselves a fainting episode. Some of the causes of distributive shock are widespread dilation of small arterioles, venules of both, the circulating blood volume pools in the expanded vascular beds, and then that tissue perfusion decreases. And again, we have certain benchmarks that we want to maintain, because once we get to a lowered blood pressure, the body will start shunting and trying to perfuse the core 4. And then if we're unable to do that, we go into acute organ failure, which is literally a death sentence. So I'm not going to go over this entire distributive table. I would like you guys to read that in your book and just make sure that you understand it. And we're going to touch on the psychogenic shock. This is fainting. The 1800s Victorian fainting couches is something that I usually try to tell the class to remember. Where you had the Victorian woman fanning herself as she laid on the couch and would just become despondent and go unconscious. It's not really shock. This is a psychological effect that just causes the body to basically autoregulate itself down, and it's very temporary and almost always self-correcting. It's very much controlled by somebody's emotions. Hypovolemic shock, I really shouldn't have to explain this to you guys. If you have a hole in the blood flow, we have a problem, right? For every ml of blood that we lose, we have an increased risk of a negative outcome. And most people can lose quite a bit, to be honest. And for those of you that are not initiated, 50 cc's of blood on the floor looks like a lake. A full liter on the floor, and you'll swear that everybody in the entire neighborhood was murdered that day. So try to get into the habit, and it's really difficult, but perhaps grab a couple empty syringes, color them with some kind of agent that's not going to stain, and look at what 50 cc's of fluid looks like on the floor, because all too often when we're dealing with charting and stuff like that, we may tell the physician this patient lost 2 liters, and they might have only lost 250 mLs. It's really hard to be credible when you're kind of falling into the panic, and the only way to actually understand this and see it is to understand what 250 mLs looks like, what a liter looks like, and not what it looks like in a container, what it looks like on the floor, because that's what we're looking at in the traumatic injuries. This is just reiterating what I just said. Every ml that we lose means it's not in your patient, which is a lost opportunity for perfusion. This is the most common causes of hypovolemia, which is hemorrhage. It's obvious or hidden, and that's an external or an internal hemorrhage. And your internal hemorrhages are going to be the GI tract. Unfortunately, many people suffer from this, where they have some kind of issue with their GI tract, and they tend to bleed into their esophagus, or they tend to bleed into their actual lower GI tract. And what ends up happening is they will end up digesting that blood if it's in the stomach or higher, and that gives you the coffee ground emesis, that really dark black kind of speckles. And then if it's below the small intestine or deep enough in the small intestine that it makes it into the large intestine, they can actually lose red blood in the stool. So your signs of hemorrhage are the signs of any shock, right? We can have people who are pale, cool, and clammy. They look cyanotic. They're just kind of in a bad way as far as mentation. It should only be something that's on your radar if you can't see the obvious cause externally. And when it's external, it makes it really easy for you to figure out where the hole is and see if you can plug it. This is just a good pictogram of the different types of shock. You have a normal blood flow, right? We have the container, we have the 2 vessels, we have the pump, and then we go into volume shock. Oops, the container's got a leak, it's leaking out, right? It's outside of where it needs to be. And then we have redistributive shock, which is the pipes have now expanded and we've lost the ability to keep pressure because the overall container is larger than it was with a set or a finite fluid volume. And then we have cardiogenic shock, where the pump itself is ineffective. So when we're looking at shock, this is that self-preservation mode. And you can see on this slide it says the brain will shunt blood from the periphery of the core to the core to protect the big 3. Now, I call it the core 4, which again is the brain, the heart, the liver, and the kidneys. And this is asking you what the big 3 systems are. In this slide, we're looking at how does this affect ABCs. And when we have somebody who's in shock, If they have altered mentation, do they have an adequate airway now? Because remember, as we've learned throughout all of the airway control situations, as somebody goes unconscious, they become flaccid, and when they become flaccid, their tongue falls back into the airway, and they can actually occlude their own airway. Are they breathing normally? Typically, somebody who's in true shock is going to be breathing rapid and shallow because they're trying to get that gas exchange to come up. Circulation. If they have an intact pipe and pumps, or I should say pipes and pump, they will initially have an elevated heart rate and an elevated blood pressure. But as those smooth muscles and the blood vessels start to tire out, eventually they're going to go into relaxation, and then we're going to have a quick shift of the blood pressure. And that's when we know we're really in decompensated shock. And the disability, again, is, are they mentating accurately? Are they able to follow your commands? So here we go with a nice pictogram. We have the beginning stages of shock. Heart rate goes up. BP is normal, right? Because the body says, I got this. I'll just speed up the heart rate. We'll figure it out. Ventilation rate goes up to match the heart rate because now we're trying to make sure that as that red blood cells are coming past the alveolar membranes, that they're trading gases, and the patient will be kind of anxious. They know something's not right, and the hormone response, epi, norepi, and the other ones for the fight or flight response when somebody's in shock are activated, and it's going to make your patient just a little anxious. Then we get into the middle of shock. The heart rate goes up even further. We're decompensating at this point because the vessels are unable to stay constricted, and so they're going to relax, and the BP is going to go down. The ventilation rate is going to increase even more because the body doesn't understand why it's not getting the right amount of oxygen to those tissues. At this point, your patient's starting to become combative because they're not perfusing their brain. And in the end, the heart rate's going to go up as high as it can go, and then the BP is going to continue to drop, and then they will start to breathe even more, and then we're in the end result. Heart rate's going to be at its peak, BP is going to drop to its lowest, the ventilatory rate's going to go up as high as it can go, and then that patient is unconscious because now that the brain is no longer able to get the proper amount of oxygen and nutrients, it is just going to shut everything down that it possibly can to be in that self-preservation mode. Compensatory mechanisms. Perfusion depends on adequate cardiac output. Remember, cardiac output is stroke volume by heart rate over a minute. So if you're looking at this, you have the cardiac output, which is CO, amount of blood pumped in 1 minute, HR times SV, right? Heart rate, that's per minute, times that stroke volume. And the stroke volume could be, I mean, it's an arbitrary number for you. You're unable to actually figure that out yourself, but it could be 10 cc's, it could be 100 cc's. It's irrelevant. It's just kind of giving you the idea of what's happening as the heart rate is going up, and if the stroke volume can meet the same demand, or if we actually start eclipsing its ability to be efficient. Remember that ejection fraction stuff. Compensated shock is vasoconstriction, increased heart rate, increased respirations, and then as soon as we start getting into decompensated, those smooth muscles in the vasculature are going to start letting go, and that produces the hypotension. When we get farther into the progression of shock, we're going to have decreased perfusion regardless of the cause. It doesn't matter. Whatever is causing the inability to get the oxygen where we need it to go is going to create shock, and the perfusion factor is going to go lower and lower and lower. So we're looking at hypoxia. The body will try to go into anaerobic metabolism, and then again, the only two organs that cannot tolerate that are the brain and the heart. And then as we go into that anaerobic metabolism, because we're not getting the oxygen and the CO2 to cross and balance themselves out for homeostasis, the acid ions are going to continue to grow. And as those acid ions grow, we're going to overcome the actual pH balance of the cell, and the cell is going to die, it will lyse, and then ultimately the patient dies. Now, when we're looking at young versus old patients, very young patients, we're talking about neonates, the toddlers, to very small children, they have significantly less circulating volume. And we've talked about this when we were talking about IVs and IOs and drip sets and how to set yourself up when you're dealing with a child and what they can and cannot have. So you may see, we'll say 250 cc's of blood from a small laceration that had serious bleeding. And to you, you're like, that's not that big of a deal. We got this, we got a tourniquet on. That might literally be 25% of their overall blood volume. That is a huge amount. And so remember, it's generally pretty good for you to have a somewhat understanding of how much blood do you expect to be in a patient of X age. In old patients, they're unable to compensate. So we'll say that you have an elderly male who's in his 70s. He's had 3 or 4 heart attacks. He's had several stents. He has a very reduced ejection fraction. And so now, because of his inability to pump against the afterload or the arterial side, right, because he's got high blood pressure and he's had this massive insult, he's unable to compensate. If you factor in something like a beta blocker, which is controlling his rate, he is really unlikely to compensate. And so any small change in his blood volume or his pressure can cause significant problems for his perfusing status. The pictogram says these are the signs and symptoms. So we have a decrease in blood pressure, nausea, vomiting, skin pale and clammy, rapid weak pulse, restlessness, confusion, decreased LOC, increased breathing rate. All of those are standard fare for you guys. So I will tell you guys this little tidbit. The nausea and vomiting comes from the body going into a protection mechanism. And because the GI tract is loaded with so many miles of capillaries to extract nutrients and fluid from the GI tract itself back into the body, that if blood flow is to cease around the GI tract because the body is shunting to the core, the food that's inside the stomach and inside the GI tract are going to start to ferment, which then is going to become very poisonous. So the body's natural reaction is, if I can't digest it, I'm going to expel it one way or the other. So just know that that's one of those things. It might be the same thing as, if some of you guys are gym rats and you guys are really, really pushing and then you get nauseated and you vomit because of your workout. That is because you've shunted so much blood to the muscles that are requiring the nutrition and oxygen that your GI tract now senses a danger. It doesn't know where that blood went, but it knows that it can no longer actually digest the food, and so it's going to make you want to eject anything that's in the contents of the stomach. In this picture, we're talking about the physical exam and the vital signs. First things first, decreased LOC. We are talking quite literally, LOC is the biggest single tattletale for somebody's perfusion status. If they have a mentation change, you know that they're either increasing their perfusion status or decreasing based on which way their mental status went. So the first sign says anxiety, and then they're going to be pale, cool, and moist. And that's literally just because the body's pulling blood flow away from the skin because it doesn't want to have to feed all of that tissue when it's trying to feed just the really, really expensive hungry organs. The ventilations are going to go up, the heart rate's going to go up, the pulse is going to feel weak, and the blood pressure is going to go down. The treatment for shock is really elemental in the idea that if you recognize it early and you treat it aggressively, you can get in front of it. We never want to let a patient get to a point where their blood pressure is dropping significantly because we refuse to initiate treatment early. We want to make sure that we give them enough hemodynamic support and oxygenation support if that's what's required. Again, if you only have 5,000 red blood cells in the blood supply, you want all of them to carry oxygen. So we want a significant amount of O2 on that person that's in shock. In regards to when we have a normal patient who's not really in shock, we don't want to over-oxygenate them. Body temperature is really, really paramount to the way that things go with your patient. You want to keep them normal temperature. And so we would like to keep them warm if we can keep them warm, because if they're shunting away from the skin, they're actually going to feel cold, even though that their body is not cold. The nerve endings are sensing this reduce in temperature because the blood flow is pulled away. And so we don't want them to expend more energy by shivering or doing anything like that because they just quite can't afford the actual extra metabolism. Rapid transport is a no-brainer. That's just something that we should all be thinking about all the time. In class, we'll be going over how to control hemorrhages. We'll talk about some ways to make some makeshift tourniquets. They're really not very effective. We will talk about some of the tourniquets that are in place, and almost all services are carrying them. They're super, super effective in creating a stop in a blood loss, and there are some really good techniques on how to do that. So just controlling a bleed is kind of instinctual, no different than if you've cut your finger and you grab it and you put direct pressure. You want to put pressure against the tissue because you want to close that capillary off, or that arterial or venual off. We want that shut down so that blood is not trying to run past it, and then we're allowing some build-up time so it can try to clot itself. The tourniquet is going to come into play if your direct pressure doesn't work and we have an absolute arterial bleed, because every time we release pressure, the cardiovascular pressure is going to blow the clot. And then we're going to splint in place, and then you can see the MAST pants. We're not going to touch those. Those are completely out of vogue now. It's still in the national scope of practice, but MAST pants are not used by anybody as far as I know. So again, direct pressure while you're elevating the extremity. You can use a blood pressure cuff as a impromptu tourniquet. In this particular photo, it says inflate the cuff until the bleeding's controlled. If possible, distal pulses remain intact. In reality, if you're going to place a tourniquet because you need that to stop the bleeding, just shut the pulses down. There's no need to kind of play the I'm going to thread the needle game with I'll increase this BP cuffs pressure so that I still kind of have a pulse, but the bleeding is slowed. That's not the idea that we have. This is just a simple triangular bandage tourniquet. We will discuss some alternative tourniquets, but the bigger thing for us to do in class is to really get you to understand how to apply a tourniquet, where the tourniquet actually needs to be applied, and then what that sensation feels like, because all too often we're actually hurting our patients with a tourniquet and you actually don't have to. So when we get into that, we'll talk a little bit more about it. This is more turning your triangular bandage into basically a cord, and then we're wrapping a tongue depressor around it and using it as a windlass. The issue here is that a lot of services are using almost like a cheesecloth kind of triangular bandage, and if you try to do this with some services, you're just going to rip through it. You can also do this with Kerlix and other things, but like I said, we'll touch on that in class. I'll make sure that we kind of go over some of our alternative mechanisms. MAST pants, I'm not going to cover it all. Just understand what the contraindications are for them, and it's literally where an injury is or if they're pregnant. So just know that in the regards of a test. But as far as I know, I've not seen a service in the last 15 years that's ever even used one. So in summary, shock, inadequate cellular perfusion. Doesn't matter what cells it is. It could be fingertips, it could be your liver. If they're not getting the right amount of oxygen and nutrition and getting rid of the CO2 and the byproducts of metabolism, that tissue is in shock. Without oxygen, cells will begin to die. We've covered on why that happens. And then you can affect survivability by really early recognition and proper treatment of shock. And in the case of sepsis, that is understanding what sepsis is, getting a sepsis protocol into place, getting fluids on board quickly, and then letting the hospital know as early as possible. The longer these people stay in sepsis, the more likely they are to die. So like I said, I hope that was pretty brief. It's 43 slides in total. I know that we can kind of get a little bit long. I'm just going to edit this down for one complete video. If you have questions on shock, let's talk about it, because this is where people make or break when they're treating their patients who are truly in a life-threatening issue, right? Be that trauma or medical, we want to make sure that we recognize what's going on. And this in of itself is one of those things where when we talk about sick or not sick, it usually falls in line with shock. So just understand that we're going to harp on this quite a bit, and we want you to treat aggressively and quickly and make sure that you're doing the right thing early.